Okay, so let's get started. Good afternoon, everyone, and thank you again for joining. Just want to confirm. So Dr. Fouad Chebib is joining us today to chat about autosomal dominant polycystic kidney disease. I'm very excited to hear his talk. A little bit about Dr. Chebib. He did his MD at University of Balamand in Lebanon, his postdoctoral fellowship at Beth Israel, and his internal medicine residency at St. Elizabeth's Medical Center. Then he was a nephrology fellow at the Mayo Clinic in Rochester, and there he was given the prestigious opportunity to be a Mayo Clinic scholar, and then he stayed on there as staff. Now he has established a PKD Center of Excellence at Mayo Clinic, Florida, and he has been part of several milestones in the care and management and research of polycystic kidney disease, helping guide how we diagnose, treat, and manage, helping approve therapies. And he's also doing additional research right now to help find even more effective therapies beyond tolvaptan. I'm very, very excited to have him with us today to share with us on this very important topic of PKD. And thanks everyone for joining us today. Thank you, Dr. Chebib, for your time, and we look forward to this.
Thank you so much, Dr. Bobart. Thank you everyone for joining. And thank you for the invitation. It's always great to even virtually come back to Houston. One of my rotations was at the Methodist, and I was extremely impressed as an immigrant or as a foreign graduate who hasn't seen the medical care in the US and how impressive the Methodist is, and still have a lot of connection with many of you in Houston. So thank you for having me, and hopefully you'll enjoy this talk, and happy to take any questions as they come along. You can ask me anytime as well. So without further ado, do you see my screen?
Yes, perfect.
Perfect. All righty. So so basically we're gonna do a little bit of updates on diagnosing PKD. So it's not only about PKD1, PKD2 anymore. There's a lot of other genes and a whole spectrum for ADPKD. There's a lot of known methods for prognosticating as well as new methods. And then how do we risk stratify, and then how do we slow disease progression as well? So there's no need to introduce PKD for all of you, but it's definitely a multidimensional, lifelong disease, a chronic inherited disease that's one of the leading causes of kidney failure. In our cohort, we looked at this, trying to define risk of rapid progression, and we said patients who reach kidney failure by their 75th percentile, and we saw in our cohort that about 75% of patients would reach kidney failure by their early 60s. So that's how we define, risk of rapid progression by age 62 or 65. That's kind of a moving target. Definitely, a lot of patients would reach kidney failure through a whole spectrum. The males by age 80, all of them most likely will be on dialysis or needing a transplant. There's about 5 years difference between males and females. So for some reason, females have a little bit better protection on the kidney side for PKD for unclear reasons yet. Hopefully in our lab, we'll uncover that soon. So it's a heterogeneous disease. The most commonly known is PKD1, which has been cloned back in the 1990s by Dr. Peter Harris in our group. There's hundreds of and thousands of these, more than 1,000 of these pathogenic variants. It accounts for about 78% of the cases. More common, more severe. On average, patients reach kidney failure in their 50s, but definitely there's also a big range for that. There's more kidney cysts in PKD1 versus PKD2, although their rate of progression is known to be almost the same, but they start off with less kidney cysts with PKD2. And then PKD2, on average, they reach kidney failure about 20 years later. This is a representative images. As you see, PKD1 truncating mutation has the most severe. Those are MRIs. You could have PKD1 that's non-truncating, and now there's like non-truncating 1, non-truncating 2. Non-truncating 2, which is kind of a missense and less severe, can behave like PKD2 or sometimes even better. This is PKD2 here, so less severe. But as we're discovering, so that kind of accounts for probably 92 to 95% of the cases. And there's still some group that don't have PKD1, PKD2. There was a talk about a third mutation or PKD3, and now there's actually a lot of other PKD3s. So there's the monoallelic IFT140. So if you remember from med school, if you have autosomal recessive disease with IFT140, you have the syndrome of short rib syndrome and a lot of congenital malformations. However, carriers of IFT140 now actually are ADPKD IFT140. So if you have only one mutation or one pathogenic variant of IFT140, you can have a milder form of PKD, larger cyst, small number. They end up having a little bit of a CKD later in life. So they have a very distinct pattern, and we're trying to predict genotype from this phenotype also using artificial intelligence in our group. Now there's ADPKD DNA JB11, which is also another new gene where you have a lot of kidney cysts, but they're mostly, the kidneys are not enlarged, and they're smaller cysts. And these patients might have a family history of PKD, and they're it's autosomal dominant as well. So these patients reach kidney failure usually in their 60s, 70s. Now, GANAB is another one that was discovered. It's milder form of kidney cystic disease, but they could have mild to severe polycystic liver disease. There's the ALGs, ALG5, 8, 9. So those kind of also have a typical feature like this. So if you see these kind of smaller kidneys, multiple cysts, this kind of reminds me of this pattern. And then there's a similar story as the IFT140. So if you inherit both copies, if you have biallelic PKHD1, then this is ARPKD. But if you're carrier of PKHD1, so any parent of the ARPKD might have some kidney cysts. And actually with Dr. Nassar, he has one case like that. And then I saw serendipitously her sister. And then we came up with, we're probably going to put it as a case report for us. This is ARPKD. And then there's also a group for ADPLD, the autosomal dominant polycystic liver disease. Those have very severe liver disease and very mild kidney cystic disease. So bear in mind that not all ADPKD patients are created equally, and they're not all PKD1 or PKD2. Now, this is kind of the natural history for these new genes. So GANAB, typically they're better than even PKD2, so they're milder. So up to 10, 15 cysts, both total cysts, and usually they have very mild CKD. For the DNA JB11, it's kind of peculiar that they have preserved GFR, but then later on, they decline their kidney function pretty fast in their 6th and 7th decade. And for the IFT140, it's a little bit better than PKD2. So they still have some CKD, but they're better than PKD2. This is a summary. So you'll see that also in the new guidelines that will be coming up this year for the KDIGO. There was some discussion about the nomenclature. We'll see what the final guidelines will be, but this is most likely going to be some sort of iteration of this, where you start adding ADPKD dash PKD1 or PKD2 if you have if you know the genotype. IFT140 is the third most common ADPKD. We talked about how it looks like. We talked about most of these things, but so the intracranial aneurysm risk is not known for most of those, but for DNA JB11, it's a possible risk. So that's an additional consideration when you're trying to screen or advise the patients. So how do we put all this together? So typically when I see a patient with kidney cysts, I like to know if they have a family history of CKD, PKD, or any sort of kidney disease. Then I look at their kidneys, if they're enlarged or not. There's no real definition of what enlarged. I think maybe 13 centimeters is something that we could consider. So anything that's above normal for age and height. And then if they have lots of cysts, so typically you don't have to count the cysts to really make a diagnosis. It's definitely a clinical diagnosis when you have a kidney cyst, a family history of PKD, enlarged kidneys, and typically you have hundreds of these cysts, so you don't really need to go and count unless you see pediatric patients. So innumerable cysts, there's progressive GFR, everything is typical for PKD. In this situation, if you have positive family history and this picture of ADPKD, you call it definite ADPKD. You can get genetic testing and see if it's PKD1, PKD2. Now, if you have enlarged kidneys, but smaller number and larger cysts, then I would think of GANAB or IFT140. If there are large number of small cysts, as I showed you in DNA JB11 or ALG8, then those kind of fit under the atypical ADPKD, and they can still have positive family history, they can still look like PKD, but they're not that typical and definite ADPKD. Now, there's another group that's the ADTKD, or the autosomal dominant tubular interstitial kidney disease, where you have a similar picture to that DNA JB11, so smaller number of cysts, the kidneys are not enlarged, but you can start picking up these other symptoms and signs. So they might have low magnesium, they might have other family members with gout and high uric acid, they might have some genitourinary malformation, or early diabetes mellitus, and I entertain this differential diagnosis often. And then there's the ADPLD, as we mentioned. Now, there's another group that doesn't have a family history. Either the family has not been screened, or the disease was mild and they were not, that it wasn't discovered or diagnosed, or it's true de novo mutation. So these patients who look very typical ADPKD like here, but no family history, we call them likely ADPKD. And then there's an indication to get genetic testing for these patients without family history. There's one mimicker that looks exactly like ADPKD. It's OFD1 syndrome. Those would be only females because male is lethal. And they would have cleft palate or some sort of malformation or congenital malformation. Then it's important. And typically they don't have a family history. So once you do the gene panel, you will pick that up. It's rare. I have a couple of patients like that, but they would, if you don't get the right history and the genetic testing, you would call them ADPKD. And you might treat them with tolvaptan, and we're not sure if they should be treated. Now, the ARPKD is a more of a childhood disease. You could have, but you could still have it in adult. I have a few patients who still have good kidney function, and they have congenital hepatic fibrosis, Caroli syndrome, ARPKD. Now, there's something that most of you as nephrologists have seen many times as consultation, where somebody comes in, they have 5, 8 cysts total, they don't have a family history, the kidneys are not that enlarged, they might have a couple of liver cysts. So what do you call these, and how do you go about it? So there's this definition that we call possible ADPKD, and we used a cohort by Dr. Andrew Rule from Rochester, who looked at CT scans from all donors, potential kidney donors, and then he looked at the 97.5 percentile of this general population, and we came up with these numbers. So based on age, gender, you could have a cutoff for that 97.5 percentile. If it's above that, so let's say someone who's 49 years old and male with 8 cysts, then that's above the 97.5 percentile. I would call it possible ADPKD, especially if they have a additional liver cyst. So when you have liver and kidney cysts, you should start thinking about an inherited process or a PKD process. And definitely would get genetic testing if needed. Most of these patients, we don't know their significance of that. Probably they behave much better than your usual PKD. And then there's all the others, acquired cystic disease, lithium-induced nephropathy, and cystic disease. We see that often. Not that often, but we see it once in a while. And then tuberous sclerosis and von Hippel-Lindau. All righty, so definitely PKD has a high spectrum, also with the phenotype. So even within, for example, 2 patients who have PKD1 truncating mutations, they could have very mild disease versus very severe disease. Even within the same family and supposedly inheriting the same exact pathogenic variant, someone could reach kidney failure in their 60s versus another in their 30s, indicating that there's a lot of other factors in addition to the genotype. There's epigenetic factors, there's environmental factors, so obesity, drinking fluids, and various other things that probably we don't know yet. But in general, although this hasn't panned out completely with the new genes, but in general, if someone reached kidney failure in the family less than 55, you could assume that it's a PKD1 mutation. About the PKD2, I'm not too sure. I think you could have many other things. So, but the PKD1, I think that's still correct. So let's say you see in your clinic 2 patients. 2 are young males with preserved kidney function. You know, in the past, you would get maybe an ultrasound and you say, okay, you have ADPKD, come back when you have, lower GFR. We'll talk about transplant, dialysis, what have you. This is actually out of practice now if we still do that. We have to give these two patients the prognosis, even if they don't know which questions to ask. It's our responsibility to tell them how severe their disease is. And through the Mayo imaging classification and calculator, right now we can estimate their age of onset of ESRD. It has a lot of caveats, this calculator. There's some work with CRISP-4 that's about to be published that could give you a little bit better. And then also we're working diligently on this, and hopefully there's a new calculator in the horizon this year from my group here. But so there's a lot of advancement for sure with PKD. So there's something called total kidney volume that came about almost 20 years ago now with CRISP, which is the Consortium for Radiological Imaging for PKD. That's a landmark study that started off with about 200 patients between Mayo Clinic Rochester, Emory, Kansas, and Alabama. That followed the patients in this iteration for 3 years, but now we're still following those patients for more than 20 years, at least the ones that haven't reached kidney failure. And that showed that the higher total kidney volume growth, the higher the growth rate, the faster the GFR would decline. So that gave us really a good prognostic biomarker for PKD to try to understand who is severe and who has severe and who has mild disease. And we know it's very important because early on, the GFR might still be preserved in the first 2-3 decades of life, and then it's going to start to decline in various rates of progression or GFR slopes, depending on their severity. This is probably not true for all the patients, but if we average it out, it can still be true. In the beginning, when you have severe PKD, your GFR is preserved, we need something else other than creatinine, and that would be total kidney volume, Mayo imaging classification, as well as some other things that are coming along, but that's still the main prognostic biomarker. And then later on in that disease stage, when you start seeing the creatinine going up, if you look at the GFR rate of decline and make sense of the TKV plus the GFR rate of decline, that's important to make sense of the progression of the disease. You can get TKV through the gold standard, which is planimetry. That's very time consuming. You need imaging analysts. Now we use artificial intelligence when we order that in our center, and it's also becoming readily available for a lot of other people. We're working on an interface that allows you to upload these and get those back. So hopefully also you'll hear from us soon on that. New York, Cornell, I believe, have this already in place, and you can upload in their system. So it's something that's definitely helpful for the field. But if you don't have these fancy tools and you don't have a big volumes of PKD and the radiologist is not happy to do that for you, then you can do your own ellipsoid equation. And I'll give you an example how we do that. So why TKV is important, again, it prognosticates. Then we took it a little bit, Dr. Torres and Dr. Erzabel from Mayo Clinic Rochester came up with this practical approach where you adjust total kidney volume by age. And by doing that, you don't need 2 TKVs to get a rate of growth. You actually get that intrinsic rate growth just from 1 TKV by assuming that all the patients start with 150 ml per meter. And then if they're growing by a certain percentage a year, then that's going to be their TKV after however year you put that first MRI or CT scan in. So the definition goes by typical versus atypical. So typical is the class 1, and they are divided into 5 subgroups, subsets. So Mayo class 1A through 1E. 1A is the most mild, the mildest forms, and then 1E is the most severe. And both, so to be typical, you need to have bilateral kidney cyst. They don't have to be the same exact size, of course, but they're mostly contributing almost equally to that total kidney volume. And you don't have any atypical or asymmetric process. Now, again, so they were divided based on what we think the intrinsic rate of TKV is, TKV growth, and that predicts that TKV rate of growth. And from that, you can predict the GFR rate of decline. And I'll show that in a second. So if there's a typical, there's always atypical. That's about 5% of patients are atypical. We call 2A as the focal disease, where you have some sort of unilateral, asymmetric, one pole. Those are the trickiest one, are the lopsided, where you have few very large cysts that are accounting for the big volume, more than 50%. So it's a little bit difficult to get that if you don't have the imaging analyst with you. but you can get the sense that this is atypical when you look at the images. So I always tell our fellows and our junior faculty that if you see PKD, you really need to see how the kidneys look and don't only look at the report, because the report will always say innumerable cysts, PKD, and they stop. You would be lucky if they give you a dimension. And if they give you a dimension, you can still mistaking this patient as with atypical as a typical patient. So definitely you need to look at the images yourself. Then class 2B is the parenchymal atrophy, where you have either bilateral or unilateral. So those patients are probably vasculopath, and they're not going to do very well, and there are not a lot of them. But definitely, if you see someone with bilateral kidney cyst and advanced or low GFR advanced CKD, you need also to make sense if their kidneys are big or not. Don't just go by bilateral cyst, GFR is low, let's start tolvaptan. So this patient, for example, shouldn't be on tolvaptan. Now, again, that imaging classification, it's nice because it can tell you that GFR rate of decline. So based on the Mayo class, you can understand that decline. Also, patients with different Mayo imaging classes reaches ESRD at different ages. With Mayo class 1E reaching in the early 40s versus 1B in the mid 60s to late 60s, and 2B reach there are only a few of them in this cohort that we looked at. They reach kidney failure in their 70s. So again, if you don't have that fancy way of getting TKV, don't be discouraged. You can still do it yourself. And you can still do it even if you don't have the sagittal cuts. So if you don't have the sagittal cuts, you can use the coronal twice in the calculator. This is the Mayo imaging calculator. If you Google ADPKD Mayo imaging class or calculator, you can see that. You can click on the link and go to that calculator. Basically, in millimeters, you would measure the maximal length of each dimension. So again, coronal, sagittal, width, and depth on the right and the left kidney. That calculates, estimating or assuming that the kidney looks like an ellipsoid, then it calculates the volume. So nothing too fancy. It's just assuming that shape. And then when you adjust for height and age at time of the image, so you can do either CT scan or MRI for that, with or without contrast. And so you'll get the height adjusted TKV, and then you'll get the Mayo imaging class. I always use this in my clinic, and I show the patients exactly where they are as compared to their peers. And I explain, if you're at risk of rapid progression, which is Mayo imaging class 1C, 1D, 1E, although I give them kind of a little bit of a bad prognosis, I kind of follow that right away, that we have ways to slow it down, whether clinical trials or an FDA-approved treatment. If it's 1B, it's intermediate. If it's 1A, it's a very good prognosis, and I reassure them. So again, these patients that they all assume they're going to either do bad or well, so they usually don't have it right, because if they have a family history, they always assume they're going to behave the same as their family member, but it's not always true. So for those who have very mild disease, it's our responsibility to give them a better prognosis so they can go on with their life. For those with their severe prognosis, bad prognosis, poor prognosis, we need to try to slow their disease process. And this is the last part where you can estimate the future GFR, and I keep kind of changing these years. So you can plug in the creatinine. It still uses the old CKD formula, so sorry for those who are very advocate for the other one. It's, in terms of calculation, I think it's still going to be valid to use the other CKD. So if you want to be really accurate, you probably can adjust the serum creatinine to get the GFR that you think is the real GFR. So you start with that current GFR, and then you, based on the Mayo imaging class, it's going to assume a slope of, let's say, 4.5 ml per minute per year decline for 1E. And that's how you're going to get how many years it's going to take to reach GFR of 10 or lower. So for this patient, I told them you're going to reach kidney failure at age 45, for example. There's another type of prognostication. It's the ProPKD, which takes into account clinical factors. So early hypertension, cyst bleeding, cyst infection, and then the genotype. And then having a higher number of 7 or above of score, you have a very high likelihood of reaching kidney failure by age 60. And that showed also there's a post-hoc or later analysis on the tempo studies for the tolvaptan showing that all the patients would have decline in their TKV rate of growth, irrespective of their pro-PKD, but the ones with a score of 4 and above would probably benefit from tolvaptan more on the eGFR rates of decline. Now we are taking also this a little bit further, and we mentioned there's this atypical feature. So how can we account for this atypical phenotype? And now with the Mayo imaging classification, it's kind of it's a random cuts, right? So you have 5 subgroups, and then you have another, the 2A, but that's, in fact, the disease is not a continuum. So by using artificial intelligence, we're able to cis-segment these patients. Now it's semi-automated. It used to take about 5 days for each case to get through. Now our team can get maybe each case, it depends on the severity, maybe in 2-3 hours, and hopefully it becomes fully automated. And we can get the total number of cysts, we can get the cyst volumes, we can get the cyst parenchymal surface area, which is what's the surface area touching the kidney parenchyma. So that helps you take away that exophytic cyst volume type or surface area type of thing. So with all these markers, as you can see, for example, this particular patient, we were not predicting well their GFR or their slopes, but then when you use total cyst number or CPSA, the cyst parenchymal surface area, their GFR slope became closer to the predicted got closer to the observed. So hopefully we can improve our predictions with these biomarkers. Now, switching gears, we talked about diagnosis and prognosis. Excuse me. So when you have PKD1 or PKD2 mutations, these polycystin proteins are not functional. And most likely, we think that these polycystin proteins are controlling the intracellular calcium. Now, this arrow is still a big black box of how that happens, but there's a consensus that there's higher cyclic AMP, whether from more production because of vasopressin stimulating adenine cyclase, or because of less destruction through less PDEs, phosphodiesterases. So in all cases, there's higher cyclic AMP, higher protein kinase A, and then all the downstream effects, which is kind of a benign tumors almost, because you have the proliferation. Also, you have this fluid secretion through chloride channels, not only CFTR, but probably other channels, and then disrupted ureogenesis. So there's a lot of mechanisms of actions for various drugs. The one that's FDA approved is blocking the vasopressin receptor, so block the formation or degradation of ATP to cyclic AMP, so formation of cyclic AMP. Somatostatin analogs would stimulate the inhibitory protein to form less cyclic AMP. However, those didn't pan out, unfortunately, in clinical trials. There's AMP kinase activators, metformins, and others. The bardoxolone kind of dropped off with NRF2 activation. mTOR inhibitor, there's potentially one new drug with mTOR1 that's more selective. CFTR inhibitor in Galapagos mangrove trial didn't pan out as well in Europe as a phase 2. And now there's a phase 1 with Regulus, which is the anti-microRNA. and that's kind of what we call gene therapies, and I think that's very promising, and it's in phase 1. So there's some early data that's promising. However, if you see a patient right now, there's only 2 options. It's either you put them on clinical trial for Regulus, or you refer them to Regulus, or you put them on tolvaptan. So what's the rationale for V2 receptor antagonist? This started off with Dr. Vicente Catone, who worked with Dr. Vicente Torres, and looked at one of the Vaptans in 2 different PKD models. And they showed that using a Vaptan, so blocking the V2 receptor, would reduce significantly the cystogenesis in these preclinical models. Then a very nice study later on by Dr. Torres' group showed that if you cross the PCK rat, so that's a rat with PKD, and so this rat has normal vasopressin, but if you cross it with the Brattleboro rats, so those are rats that have central diabetes insipidus, they make about equivalent of 12 liters of urine a day. So without vasopressin, so when you give PKD a central DI, they have no cyst whatsoever. They cure the PKD. And then when they gave back the DDAVP, it rescued the cystic phenotype. So basically, with no vasopressin at all, we cannot have PKD. However, we cannot live without complete vasopressin. At least it's going to be very difficult to maintain that. So the next best thing is to block it pharmacologically through a V2 receptor antagonist. So that was the rationale for the biggest trial in PKD called TEMPO 3-4, looking at the efficacy and safety of tolvaptan in PKD, recruiting internationally more than 1,400 patients. And it showed that with tolvaptan as a group who received tolvaptan, the TKV rate of growth was half of the placebo group. And then it did have an effect on the GFR slope by putting a brake on that by about 30%. So instead of losing negative 3.8 per year, the tolvaptan group was only losing negative 2.3, 2.6. So this was the TEMPO trial. Then REPRISE was an FDA requirement in a sense that they wanted a more advanced CKD, so GFR 25 to 65. They wanted older patients, and they want to also wanted to make sure that it's safe on the liver. So also this 1-year trial showed that tolvaptan is very beneficial. This was the open label, same thing, also with lower GFR, so down to 15 ml per minute. Tolvaptan continued to work. There was also an open label for 4-4, as well as our data from all the patients who received tolvaptan through the trials. At that time, we had up to 11 years. Actually, yesterday I saw my one of those patients, and she's now at 20 years on tolvaptan, enjoying very good, better kidney function than without tolvaptan. So we showed that it's an effect, the effect is sustained and cumulative. So every year you're on tolvaptan, you're gaining that additional 1.3, 1.6 ml per year, and it's adding up. So if someone has been on it for 10 years, they gain 13, 15 ml on top of their natural history, or better than their natural history. So how did we put that together in terms of how do you prescribe it? Who do you prescribe it for? The FDA approved it for patients at risk of rapid progression, and they didn't give more details on that and left it to us to decide. So we came up with this algorithm where, one, you need to make sure you have a typical ADPKD. Two, you need to have Mayo Class 1C, 1D, or 1E. Then those patients are at risk of rapid progression. GFR should be above 25. At that time, with the REPRISE study, it only showed that patients with 18 to 55 have the benefit. And I'll tell you what we do with 56 to 65 in a minute. But at that time, we said recommend tolvaptan for these patients. For patients above 55, we said it's a shared decision. But now we have a post hoc analysis that helps us guide that. With Mayo Class 1A, I would definitely reassure them, making sure also it's ADPKD and it's not like ADTKD or something else, or Mayo Class 2B, right? So you need to make sure that you classify them correctly. But if it's a true 1A, then I would reassure them. For 1B, I would get another MRI or CT scan in a 2 to 3 years' time, especially if they're younger, because the separation is very small when they're younger. So any small error in measuring TKV, it can put them below or above, and especially if they're close to 1B, 1C, or especially 1B, you want to keep a close eye on them. Maybe get another MRI in 1 year if they're 1B on the border, right? So again, those are best guesses, and the disease is a spectrum, and you don't want to just be so defined with. You need to put it in the clinical context. And then everybody else definitely monitoring, and then what we define basic optimized management with controlling blood pressure less than 110/75 based on HALT study for patients who are at risk. Now with the KDIGO guidelines, they're also saying, I have to adjust that, 120/80 is for everybody. And then moderate sodium restriction for dual reasons. One is blood pressure, but also to have less osmolar intake, so you can suppress your vasopressin easier with less fluids, with less hydration. We still recommend increased hydration for everybody, although the study in Australia didn't pan out, where they looked at patients with PKD who received a guided water prescription versus ad libitum hydration. The conclusion was there was no difference between the two groups, but the detail is really patients are it's very hard to reach 3-4 liters of urine output without a lot of commitment, basically. And similar probably with your stone patients and what have you. It's hard to get up to that dilute or hypotonic urine unless you really cut your salt, maybe your protein, and then really increase your hydration. BMI has a lot of association with worse PKD, worse outcomes. So definitely I recommend for our patients to try to lose weight if their BMI is above ideal. Now, let's say you identify this patient as a candidate for tolvaptan. Definitely, you want to discuss with them the risks and benefits. We talked about the benefits. Then you want to go over contraindications. So those are obvious contraindications. Those are all in our paper. You feel free to go for more details. You know, sometimes these CYP3A inhibitors, they kind of get me because I just had a patient. I was concerned about the interaction and I started at 30-15 and then still it was almost like giving him more than 90-30. And then so we need to enroll the patients into REMS program as well as us being REMS certified. Then and we took kind of what the trials have done and then added a little bit of a practical approach based on experience. So in the trials, there was this cross between tolerability and efficacy. So definitely 90-30, so 90 milligrams in the morning, 30 milligrams early afternoon is the best, right? But most patients don't tolerate that. So in the trials, they had the 45, then 15, 60-30, 90-30, and all of them had very good efficacy with some good balance on the tolerability. Now you can start that in your practice, or I've heard that some people start all the way up and then come down. Some people start all the way down and then come up. We do 45, 15 and then try to titrate up. If they don't tolerate, we kind of go down. You can do it every month. The label says every week, but you can do probably every month is more practical. You can go up and titrate up. You can titrate up to tolerability. That's what the Europeans like to do. And they said, this is what the trial did. You don't need to do anything else. Just keep pushing until the patients tell you they cannot tolerate it. For us, we use the urine osmolality in the morning. So it's the morning urine osmolality before the morning dose. And that's a very important detail because a lot of patients end up doing the urine right after they take their tolvaptan, and definitely it's going to be a urine osmolality of 50 or 100. It doesn't give you a good idea. You want the trough level, right? So you want the urine osmolality before the morning dose. And if that's less than 280, then you're reaching a hypotonic urine, a suppressed vasopressin across the day, 24 hours, because that should be the highest after, 12, 18 hours or 12 hours or so from the last dose. Less than 12 hours. I didn't do the math, sorry. And then you can monitor efficacy, and that's still a big gap in the field on how do you know if the treatment works for your particular patient. You can go by what you expect would have happened and then what you're seeing right now on the GFR rate of decline, TKV rate of growth. You can go also by some quality of life measures. Then definitely it's very important to have it safely. And for the first year, you need to check liver function test every month. And then after that, every 3 months. And if the sodium is high, sodium is low, you can adjust. If the LFTs are deranged, then we have also the protocols for that. The risk is about 5% to have hepatotoxicity, but then in the real world with the REMS data, about 8,000 patients were checked since their approval in 2018, and the risk is much lower than 5%. And then there's about 0.2% of really severe hepatotoxicity. So this is how I tell my patients. So it's all about the context. So if you just tell them it's going to be toxic to your liver, of course, no one is going to be on tolvaptan. I don't want to prescribe it. But if you understand the risk and how you mitigate it, make sure that your patient is not heavy on the alcohol, make sure they know when to stop if they're going on a cruise, wedding, some big events, or also make sure that they don't get dehydrated. And if they're having diarrhea or they cannot have access to fluids, they need to stop. Now, also a big question that always comes up is polycystic liver disease a contraindication? And definitely it's not. So all the patients would have some sort of PLD. Some have severe PLD, but PLD does not affect the hepatic function. Hepatocytes, it's more biliary. And then it's not contraindicated. This is the protocol in terms of when to stop. We made this all kind of nursing protocol to help us make sure They review the labs and they do it quickly and try to elevate the burden on the prescribing provider too. So we talked about the benefit, but how do you tell that to your patient, right? So if we tell them 1.3 ml per minute per year, is that going to resonate? So we did some extrapolation and said, if you start early, you're going to gain more. So that's one take-home message. But also the second take-home message is, as you're adding up these benefits, you're going to see kind of pushing away that ESRD onset. And the most thing that resonates with our patients is telling them every 4 years of treatment, you're going to delay the onset of ESRD by 1 year. And for those who have seen their loved ones on dialysis, they definitely understand the importance of that. There was another group who looked at that in a different way, and it was similar in a sense of how many years you delay after how many years of treatment. Now, for the patients who are older than 55, so 56 to 65, we have the data. Now, it happened that in Reprise, this particular subset of patients had slow progression. Their GFR rate of their slope was about 2 ml per minute per year. That's almost like, you're aging, right? So it's definitely milder PKD for that particular group. So what we've done is we looked at all the patients who received tolvaptan with this age group, and we had about 95 patients. All of them were in CKD 3 and 4. And then we matched them based on age, sex, and then some subgroup, we matched them based on their TKV. Not all of them had TKVs, but definitely with their GFR. And then we had a good match of 95 patients, other 95 patients who should be almost with the same severity, typical severity, or typical rapid progression that are 56 to 65. They're not slow progressors. And we saw that there's a good difference between the patients who received tolvaptan versus the standard of care. And we said and this particular subgroup had this characteristic. So they need to be 56 to 65, GFR rate of decline more than 3 ml per minute per year, and they should already be in CKD 3 or 4. If they're not having that CKD, that means they're slow progressors. So it's important to kind of capture that. Then we added one additional safety, and we said it needs to be 1C, 1D, 1E to make sure that the GFR, the low GFR and the high GFR rate of decline is not from something else. Like they're not diabetic all of a sudden. They're not losing kidney function from diabetes or oxalate nephropathy or NSAIDs or something else. Now, there's this other post-hoc analysis as well by Dr. Torres on the data from the Reprise and open label trials. And this mostly showed that patients who have low GFR, so 15 to 29, 15 to 24, 25 to 29, continue to have benefit from tolvaptan. Now, one could interpret this as to start tolvaptan at lower GFR, but the way how I use this data, and I like to use that data, is it means that if you have already started tolvaptan at GFR of 30, 40, 60, and now your GFR is 25, 15, you will still get benefit from tolvaptan. So it's good to continue tolvaptan until you need transplant or dialysis. I personally would not start someone who has GFR of 15 or 20 or even 25. I have a good shared decision-making discussion with them at 25 of GFR. So this is what we've talked about already. Those are the older patients, so they need to have this CKD with a GFR rate of decline and continue tolvaptan until they need the preemptive transplant or they start dialysis. Typically, maybe a few days before, maybe 1 week, you can stop if they have a scheduled preemptive transplant. Sometimes the insurance can get to you here and they tell you GFR is less than 25, you should stop. Then show them that other data and they should approve it. So a lot of times people ask about Mayo Class 1A. What do we do with them? Again, reassurance, especially if everything fits that is 1A. But all of them, we should still help them slow their disease progression. So they need to be at their healthiest possible. So stopping smoking, getting to normal BMI, increased hydration, and what have you. So that's for all PKD patients. Then 1B is still intermediate, and we still have some work to do there, especially if we find a treatment that's not that cumbersome as tolvaptan. something maybe similar to how you prescribe lisinopril, and you don't have to worry too much about labs and side effects, then that would be good to prescribe to 1B, because we still need to slow their disease process. And then the 1C to 1E, we talked about that. We talked that we put together something called the PKD diet, because that has been a big discussion in the field. So for any PKD patient, we like them to reach a normal BMI. There's this talk about all these sorts of dietary interventions. And I didn't put the table here, but there's not a lot of clinical studies. There's smaller clinical studies. Definitely, we like patients to reach a normal BMI of 25 through different. You can do any dietary intervention basically, but I think caloric restriction is the one that's commonly it's felt that it's the risk and benefit. The benefit outweighs the risk with caloric restriction. We can do intermittent fasting, time-restricted eating, or ketogenic diet, but those dietary interventions, we don't have the long-term side effects or effects from them. Then you want to have a hypotonic urine, although that study prevent ADPKD from Australia was negative. We still like to lower AVP or vasopressin as much as we can. For proteins, you can be up to 1.3 gram per kilogram if you have a normal GFR. Then all the other things we don't want to forget to keep them very healthy. All right, so holistically, maybe we can spend 5 more minutes and then we can take some questions. But I'm sure you see a lot of patients with these chronic pains. Now, there's a few different options, not a lot of options. For those who have very typical, very dense, hundreds of these cysts, probably you cannot do much except renal denervation, celiac plexus block, spinal kind of spinal. There's like this procedure or this device that you can stimulate the spine. I'm blanking on the name now. And then the cyst aspiration and foam sclerotherapy. So this used to be probably you know it as alcohol sclerotherapy or cyst aspiration. So if you just aspirate the fluid, it's not going to do anything. It's going to fill right back up the second day. Most interventional radiologists know about alcohol. So you want to burn the epithelium around that cyst so it doesn't secrete the fluids. But alcohol is not very effective. The group in Toronto by Dr. Pei has worked on something called sotraticol or the foam sclerotherapy, same material that is used in varicose veins. And it worked very nicely in their group as well. And we adapted that 7 years ago, and we have very good results. So it's basically for select patients who have few big kidney cysts that we think it's going to help their pain. It's only for pain management, although in this study they showed that the GFR went up a little bit, but I would not do that for that reason. Sometimes we need to take those kidneys out, the native nephrectomy. In our group up till 2004, it used to be a pre-transplant nephrectomy. And we saw that there's a very high blood transfusion rate. They get sensitized, so we stopped doing that. Then there was the era of the post-transplant, and that's, I think, is still the most reasonable approach, is after you give them a kidney, the kidney is happy, you're happy, and then 6 months later, you go in, you take the kidneys out. The reason is most surgeons don't like to do the post-transplant nephrectomy because it's a huge surgery. It's a big surgery to take those kidneys out. There's a risk of hemodynamic instability. However, if your surgeon is a big advocate for simultaneous or concomitant transplant with a native nephrectomy, some patients love to do 2 birds in 1 stone. But many are still reluctant or nervous about it because these patients end up needing ICU a little bit more. They might have a little bit of hypotension. So it's a little bit compromising the allograft, although this is our surgeon and our group in Rochester. But for example, in Jacksonville, I kind of favor the post-transplant nephrectomy. Kidneys do shrink after transplant, so keep that in mind. If it's borderline pain, you think, it's not that clear of an indication to remove it. So removing kidneys is mostly pain, but also cyst infection, cyst bleeding. We don't take them out because of space for the most part. So again, these kidneys shrink after time, and we have a nice study on that. PKD is definitely a systemic disease, so don't forget all the other things, in addition to the renal manifestations, there's definitely the intracranial aneurysm that you need to keep checking that on a regular basis. Even if they get transplanted, that risk doesn't go away. The hepatic cyst, is the more common, right? So polycystic liver disease is almost in all the patients. They will have, 10, 20 cysts there, but a lot of patients have mild disease. So that's what we call the Mayo type or Schnell-Dorfer type A. These patients have little symptoms, focal cysts, no real to worry. Type B is they have more severe symptoms, but the definition is mostly about the segments. The cysts are focal. There's more or less at least 2 segments that are normal. Type C is very cystic, but there's at least 2 segments next to each other that are preserved in a way. They still can be cystic, but they have still some normal parenchyma. Type D is where everything is cysts. And so the management differs for these. Type A, you observe. Type B, you do foam sclerotherapy or cyst fenestration. Type C, you do a partial hepatectomy. And then type D, the liver transplantations through an exceptional approval, because their MELD is going to be normal or low. So the partial hepatectomy, our European colleagues don't believe in it because they think the liver is going to grow right back. And why do you get them into a partial hepatectomy? Just transplant them with the liver. So we have also a couple of pioneer surgeons in our group, and we showed that it's quite sustained reduction in liver volumes. So we looked at all the volumes before the partial hepatectomy and then throughout the years, and we showed that it continues to be sustained. We also show that after so the patients with severe PLD are most commonly females, although we see some males. We show that after menopause, and we think around 48, 50, these livers can decrease in size, although some would continue to grow, but some of them would decline in size. So if someone is close to that and you're debating if they need this big surgery and if they can tolerate based on symptoms, then you might want to wait a little bit. And finally, so intracranial aneurysm, how do you screen? Europeans as well love universal screening. They love to screen everybody every year almost. The US is something different because probably the costs are different. So we came up with this targeted screening based on our experience. And we said if someone is 20 to 70 with good life expectancy, the main risk factors is definitely having a family history. That's the biggest one. So family history of intracranial aneurysm puts them all the way up to 22% risk, versus the general ADPKD risk is 7%, so 5 to 10%, and the general population risk is 2 to 3%. So ADPKD in general, they will have higher risk. So someone with personal history or family history, smoking increases their risk, hypertension increases their risk, and some ethnicities as well. So this is maybe a little bit more detailed for that, but for sure we like a shared decision for those who have general. Then with the high risk, definitely I would strongly advise to get a brain MRA. So that's without contrast, but you need to make sure that you tell the radiologist you're looking for a brain aneurysm, or you can do a CT angiogram. Now, once you screen, most of the times you're going to have negative finding. You will repeat in 5 years if it's high risk, and if it's normal risk or general risk, it's about 10 years. Then if there's a positive finding, it depends on the size and your group of neurologists and neurosurgeons. Typically, if it's less than 5, it's okay to monitor. I don't send them right away to the neurologist or neurosurgeon, but you could if you want to. So typically, I would get serial MRAs. And then if it's above 5 millimeters or there's anything that's unusual there or any significant growth, we will send them to the multidisciplinary team. So I'll skip through that. We talked about all of these. Definitely, there's a lot of milestones, current trials right now, whether in Europe, in Australia, or here. Lots of interest from various pharmas. I think there's 16 companies looking at PKD now. This is in phase 1. This was supposed to go in phase 1. It's delayed. I'm not sure if they're going to continue. This is Vertex is working towards a polycystin 1 corrector for a small subgroup for now. And then there's a lot of other exciting things coming our way. And with that, I will stop and thank you for your attention.
Excellent. I welcome any questions from the group. You can put it in the chat or feel free to voice your question.
Thank you so much. Wonderful presentation, and thank you for summarizing all the data. And thank you for answering my questions that I had sent to you ahead of time. So appreciate it. So now I can ask you another one, which is, which genetic panel are you using?
Yes, great question. So there's a little bit of a debate first, who you screen, who do you get genetic testing? So if you asked me 5 years ago, I would say you don't need genetic testing, just get an MRI, CT scan, and you're good to go. And now that we're understanding all this spectrum of PKD, it's important to have the right diagnosis, 1, accurate diagnosis, 2, prognosticate with the genetic testing, and 3 is, as these new things coming in, polycystin 1 correctors, there's other company working on other things like similar to that. You need all this data ahead of time to know which patient is going to benefit from that. So definitely there's a little bit of trying to push the envelope to get genetic testing for everyone. So for me, I offer it to everyone. Others think this is maybe an overkill and they would just offer it for those without family history, with some atypical scenarios, right? Or young donors that you need to rule out PKD. The gene panel, I use 3 different ones depending on the situation. So I use Renasight as a panel, particularly if I'm looking at IFT. So PKD1, they do very good job with PKD1, PKD2. They also have the IFT 140 and the rest. So they do very good job with that. And also I do it if there's something that's not fitting, that I need a comprehensive panel to look at everything else. The second panel I use sometimes is GeneDx. Also, they do very good job. It's a smaller panel, but it doesn't have IFT 140. And then both of them don't have DNA JB11, or at least not yet. So if I'm thinking about DNA JB11 as a first line, or as a first high on the top, I would send Variantix, which is a little bit more expensive. And we have genetic counselors who help us with that, but also medical genomic specialists. So it's a little bit individualized on that, yes.
Dr. Chebib, this is Wadisuki. Congratulations on this beautiful and extensive update. I have a question that has to do with the liver in particular, and that is that proliferation of cells is obviously a component of polycystic kidney disease, but certainly of polycystic liver disease. And you have not mentioned any effect of the therapies that have been tried for polycystic kidney disease on the liver. Is there any evidence, especially of growth inhibitors, that any of the medications that have been used have had any effect on the liver cysts?
Yeah, great question. Thank you, Dr. Suki. So to answer the question, yes, there are a couple of therapies. They're not approved. Well, there's one of them approved, I think, in Europe, which is lanreotide. But somatostatin analogs have been shown to be pretty good with polycystic liver disease. So octreotide is one of them, and it's helpful. Instead of kind of going to 5% a year growth, then it kind of goes all the way down, maybe to 1 or 2%. It does have many of those somatostatin analogs have side effects of diarrhea, other GI side effects. It's almost impossible to get those to patients because it's off-label and it's very expensive. So we have very, very hard time get them to the hands of the patients. But octreotide was shown to be significant, lanreotide as well. And I hear that in Europe, it's going to be approved, I think, for polycystic liver disease. But they all kind of have similar, the pasireotide or something from like the similar, it does have a side effect of diabetes, inducing diabetes. So they do have a little bit of a side effect there. Tolvaptan on PLD, we don't have the answer yet. We think there's some hypothetical role for that. But unfortunately, with the Tempo 3/4, they didn't take the whole segment for the whole liver, for the whole abdomen, so we don't have the data for that yet, or we probably won't ever have the data. Yeah, so that's on the polycystic liver, and we use it mostly for patients with severe symptoms and severe PLD, and they don't have any other surgical or interventional options.
Thank you, and congratulations again.
Thank you, that's okay.
All right, so it's 1 o'clock. I know.
I think there's one more, maybe quickly.
Sure.
Dr. Rubin,
That's
yes.
from Dr.
Thank you for
Hussein.
what. At the ASN Open Forum, a recent question due to the economics of tolvaptan was posted, which is, has there ever been a randomized comparative trial between water loading and tolvaptan in PCK, in humans?
Yeah, the only trial was hydration versus ad libitum, so there was no head-to-head, and you can't, you imagine why, because it takes a lot of money to sponsor these, and of course Otsuka is not going to sponsor something against tolvaptan. So there's no studies yet. I hear you that it's expensive and the economic of that. However, the hydration alone, as compared to ad libitum or plus ad libitum, did not show good effect. So there's a little bit more. If you read the fine print or the discussion in the Tempo 3/4 and the reprise, there's discussion of tolvaptan. In addition to blocking the V2 receptor, there's potentially some anti-inflammatory. There's some other things that we're not measuring yet. It's beyond just kind of inducing the aquaresis. So the on-target effect is the aquaresis, but I think there's a lot of other things that blocking the V2 receptor is doing that's beneficial to PKD. And again, it's not the best, it's the only treatment, but it's not the best treatment. There's definitely a big gap that we need to fill.
Thank you.
Absolutely, thank you.
Thank you very much, Dr. Chebib. Thanks everyone for joining, and we'll see you all again in 2 weeks. Take care.
Thank you, everyone. Thanks for the invitation.